Good morning. Good morning. Good afternoon. I want to go ahead and welcome everybody today to UCSF Family and Community Medicine Ground Rounds. My name is Margot Venner, and I'm delighted to welcome our speaker today, Dr. Martin Shapiro. The talk that he will be giving today is The Present Illness, American Healthcare and Its Intractable Afflictions. Just as a reminder for everyone today, our session is being recorded. If you'd like to go back and review this session or see prior sessions, as always, you can review all sessions which are uploaded on the Department of Family Medicine, UCSF Department of Family Medicine website. Today's session is designed to be interactive. We will hope that you will use the Q&A box to type in and ask your questions. Dr. Shapiro would love to hear your thoughts and comments as well. Also, last but not least, I want to thank our wonderful tech team. As always, Roy Johnston, Erigo Mitchell, and Benjamin Wallen, thank you for your help. The topic that we will be talking about today, as I mentioned, is the present illness, American healthcare and its intractable afflictions, with Dr. Martin Shapiro. Today, Dr. Shapiro will explore the reasons why it's been so difficult to solve many problems in American healthcare. He identifies three underlying phenomena that shape the behavior of physicians and their organizations, and really the healthcare sector. These include the commodification of healthcare and health by all groups of participants, consciousness of the actors, their attitudes, values, expectations, interests, and perceived needs, and the communication structure of the relationships amongst these groups, which sometimes tend to reinforce the worst tendencies in all groups. He'll discuss a wide range of steps that can be taken to address these many problems, but the meaningful reform will need to be broad and deep. Dr. Shapiro obtained his medical degree from McGill University. He's from Canada, a place with a good healthcare system, and his PhD in history and Master's of Public Health from UCLA. He's a professor of medicine at Weill Cornell Medical College and Distinguished Professor Emeritus of Medicine and Public Health at UCLA. Prior to being at Cornell, Dr. Shapiro spent many years at UCLA, where he was chief of the Division of Internal Medicine and Healthcare Services Research for 25 years. He's a general internist who's practiced both inpatient and outpatient general medicine. He's also a health services researcher who studied accessibility of health and health disparities, scientific misconduct, pharmaceutical advertising, and other topics. He is interested in empowering communities in relation to the research enterprise and trying to improve health and healthcare for those most in need. And I think of great excitement to me is that he has written a new book, which is right here and will be in the chief residence room first. I'm not totally sure if you can see this on Zoom. Maybe you can, maybe you can't. It's called The Present Illness, and I'm just going to read one excerpt from the back because I think it's so, it just really explains why we should all be reading this book. It just says, in the present illness, Dr. Shapiro weaves together history, sociology, medical research, and his own experiences as a physician to explore the range of afflictions impairing U.S. healthcare. And he explains why we can't fix the current system without making significant changes across our society. With a sharp eye and ready humor, Dr. Shapiro dissects the ways that all groups participating in healthcare reinforce a dysfunctional system. I am very excited to welcome Dr. Shapiro today. Thank you for giving this talk, Dr. Shapiro.
I am delighted to be here. And I just wanted to say, in terms of disclosure, that I don't believe in reincarnation. So I'm not reincarnated as the resident Martin Shapiro in your program. I'm actually a distinct being. Anyways, so when I was a medical student at McGill many years ago, I did a wonderful elective in metabolic research. It was in endocrinology in the metabolic research unit at UCSF. And I had a really great time doing that. Besides having the opportunity to explore San Francisco and go to City Lights bookstore, plus another one that was a little edgier called Modern Times. I'm not sure if it's still there. And getting ice cream from what I believe was Uncle Gaylord's. Don't know if they're still in business. A couple of things stick out other than the learning that occurred. One was that I picked up a button that I often wore subsequently that said, criticism is an act of love. And the other was a conversation I had with a UCSF medical student at the time. We were walking through the halls up at Parnassus, and where they had pictures of all the medical school classes. And I commented that there were very few Black faces in those classes. And this student, who was a progressive Latino, said to me, he said, well, there aren't that many Blacks in San Francisco. So I think it kind of reflects what was a pretty pervasive blindness to one of the many problems that our healthcare system had. And some people are trying to address these now, but we've got a long way to go. So I'm glad I have an opportunity to talk to you about my perspective on the healthcare system. I entered academic medicine, like many others, with the belief that producing evidence on the shortcomings of the system would lead to their amelioration. But we fell very far short of that aspiration. So I was, as you heard, at UCLA for a long time, and my wife got a chance to be an academic chair at Mount Sinai Medical School in New York. I moved along with her and had to decide what I was going to spend my time doing. And I decided to write a book about healthcare. My goal in writing this book was the hope of engendering serious discussion about how we can get back on the right track. In writing the book, I had no difficulty enumerating many, many problems in healthcare, and it became apparent that they weren't just bad luck, they were linked. And to understand why that might be, I had to consider things quite broadly, and you'll hear some of that in the talk today. I learned a lot, and it took a lot longer than I expected, and the process was very humbling. But I encourage you all to think about stepping away at some point in your careers from the busyness of what we all do in academic medicine, and attempt to place what you've learned in a broader perspective about our system's accomplishments and also shortcomings. We need that. Hopefully, if pre-med students, physicians in training, practitioners across the specialties, and leaders of organizations are exposed to ideas and consider them, it might engender some humility about American healthcare and shake some of them out of their career-driven complacency and complicity. Okay. I have no financial conflicts of interest to declare. I am a generalist, and some of what you'll hear will reflect that perspective. So in the view of many, these are the best of times to be involved in healthcare. It's a time of scientific breakthroughs, an age of exploding knowledge of mechanisms of disease, an epoch of extraordinary profits if you're in a healthcare business, a season of life-saving medical interventions, the spring of personalized medicines, and in the view of some, will all approach immortality. But is that the whole story? It's also a time of clinical neglect, of blissful ignorance towards chasms in health, of personal bankruptcies due to medical debts, of choosing whether to pay for your health care or for other basic needs. Medicines that are personalized can be extremely expensive, and it's the winter of avoidable deaths for many whose problems lack priority, and immortality certainly isn't a frontline consideration for those who are facing the prospect of premature death. So why is it so hard to fix healthcare in America? If we're going to make more headway, I think we need to think about it in a different way from we have up till now and act accordingly. So what's rotten in the state of healthcare, you all know, the disparities in access and health, the high costs and the poor outcome are the most prominent features of dysfunction. And I'm not going to dwell on these for very long. The lack of insurance for many, even after passage of the Affordable Care Act, underinsurance for even more people, health expenditures that far exceed those in other countries as a percentage of GDP, and poorer outcomes, which we'll come to in a minute. But in terms of cost, the US wasn't always such a spendthrift. And you can see back around 1970, the percentage of GDP going for healthcare was about the same as in Canada. But they separated as Canada developed its universal system. And you can see similar patterns elsewhere. And in terms of outcomes, in terms of life expectancy, you can see that over the last 40 years, the US, which was pretty similar to other countries with advanced economies, has deviated rather severely from them. And is just before the pandemic was at 78.9 years, even dropped a bit at that point. You can see the US here over this 50-year period that's portrayed. Almost every country's improved a great deal, but the US less than most of the others. And we're now 3 to 6 years behind most of the countries with advanced economies. So why has it been so hard to pull the right levers and create policies to solve these problems? I believe the problems are multifaceted and go well beyond the usual targets of policy and of research. But the ways in which different groups of actors conceptualize health and healthcare, pursue their interests and perceived needs, and interact based on these conceptualizations create impediments to a system that's rational, just, and efficient. And let's look at the groups of actors that I argue all stand in the way of equitable, efficient, and effective care. Practicing physicians and their organizations, medical schools, corporate providers of medical care, including hospitals and health systems, but also pharmacy chains, nursing homes, and so on. Other corporations in healthcare, the manufacturers, the health insurance companies, the investors, but also the scientists, the scientific organizations, government, employers, and indeed also patients, their families, employee groups, and many community organizations often stand in the way of progress. I believe that three phenomena shape the circumstances and experience of care in contemporary society: the treatment of healthcare and health as commodities by all actors within and without the system, the consciousness of these groups of actors, their attitudes, values, perceived needs, expectations, interests, and capacities condition their conceptualizations of health and healthcare and their behavior, and the nature of their communication and relationships among these groups of actors, which reinforce the existing arrangements and make change more difficult. A story. Luis was a 23-year-old man from Central America with a mild learning disability who lived with his parents. He had congenital immune deficiency and required immunoglobulin infusions from birth. Early on, he developed hep C infection from an infusion. When he was 7, his parents moved to the US and he came to my teaching hospital for his care. We took care of him for about 15 years. His hep C progressed to end-stage liver disease. The liver transplant service declined to list him for transplant, saying he had no insight about his illness. His parents both worked, and he didn't take medicines consistently. They believed if he were transplanted, he would reject. My residents and I sat down with the family to discuss his situation in Spanish. It turned out that Luis never had missed a single dose of medicine. And because of his illness and disability, his loving parents had chosen to work different shifts, so he was never alone if he needed a medicine or became ill. He also did understand the illness and the importance of taking meds. His parents were totally devoted to keeping him well, but without the procedure, he'd die. We shared this information with the liver team. They noted he was undocumented, and while coverage had been arranged for routine care, he didn't have insurance to pay for the procedure. I spoke to the transplant surgeon, noting the background of his care. He said he would waive his fee, but we would have to get the hospital to cooperate. The associate director of the hospital, which ran annual surpluses of about $200 million a year, told me that it was a considerable expense to do a transplant, and even if they waived charges, the patient would be unable to pay for his medicines in the long run. I implored him to pursue it, see if Medi-Cal or others would cover, given his long time living in the country. He said they tried, but Medi-Cal refused. We were very upset. The hospital's decision was final. The only hope was to get him to another hospital that might try harder. And a hepatology fellow who was equally frustrated contacted the other programs in the region and found one that would take him. And we learned that they were able to get the procedure authorized and he was placed on the transplant waiting list. So the story of Luis illustrates many salient issues, notwithstanding an apparently acceptable outcome. The system failed him. Even after we showed that he'd be able to take his meds, that his parents were extraordinarily supportive, his time in the country was mitigating, he would have been sent home to die. In American healthcare, some lives are cheap. And in cases like Luis's, the problem isn't only the tunnel vision of doctors who fail to collect vital information, but also the priorities of health systems, including America's so-called best hospitals. A far from acceptable quality of communication with patients and families also can stand in the way of people getting the care that they need. So my main point today is that fixing healthcare is so difficult because of the interplay of consciousness, the commodified world of healthcare, and the toxic relationships and problematic communication that pervade. Resolution of these challenges requires acknowledging this interplay and addressing it. So I'll present some potential approaches to the problems I identify, but few, if any, will come to pass unless we broadly address these phenomena that undermine progress. Let's talk about the different players. Start with the major health systems, which include academic and non-academic ones, those for-profit and those supposedly not-for-profit. The behavioral distinctions aren't clear. They contribute to the problem in a number of ways. Early in my career, my department had a retreat, and the keynote speaker was from Henry Ford Hospital, the senior executive in Detroit. He regaled us with an account of their business strategy and how they increased sales. Then he paused and said, which you refer to as hospital admissions and outpatient visits. That was clarifying. But far too often, these systems seek to maximize share of covered lives, maximize reimbursement, minimize risk, meaning poor people who need lots of care, contract with healthy populations, develop lucrative product lines, prioritize expensive procedures, make deals with industry, strive for 9-figure surpluses, and reward executives with 7 or even 8-figure salaries, of which 30% nationally are based on financial performance, as they call it. Can we change the incentives of these corporations? Well, good luck. But we could start, if we're going to do something, by not paying CEOs salaries up to 50 times what some of their doctors earn, and their bonus payments, and require full participation of all clinicians in Medicaid for a health system to maintain its nonprofit status. As for other corporate interests, the producers of goods are also interested in sales and in inducing demand. Pharma and the biologics advertise shamelessly to patients and providers, convincing the former that their products will extend life or improve its quality without regard to how much or at what cost, and raise prices when they can, often recruiting academic economists to justify their exorbitant price points, extend patents with minor modifications, which they call evergreening, and restrict competition and fight to prevent negotiation of prices. Equipment manufacturers do much the same kind of thing. And what they do is let it be known which institutions have bought their latest versions of their technology, which puts pressure on other sites to do the same. As for information systems, they're an oligopoly in which pricing is prohibitive for small practices. They increase the cost of care and the work of the provider for benefits that may or may not be forthcoming. The health insurance industry, of course, sees single payer as an existential threat and resists expansion of public coverage, but they also prod their allies in government to privatize lucrative components of existing public programs and add to problems, because to maximize revenue, they minimize risk by denying coverage, offering products with large co-payments and deductibles, and they have very high administrative costs. Their co-payments, deductibles, and denials are an enormous burden and saddle many with insurmountable medical debt. Nursing homes, pharmacies, and dialysis companies are motivated to maintain or even dramatically increase their revenue streams. And hedge funds have moved heavily into the health sector and even into primary care. They seek to inflate value by maximizing billing revenue and cutting corners and selling at a large profit. Some of them talk about value-based care, which sounds great, but when one such company recently was acquired by CVS for $10 billion, the value they spoke of was offering, quote, offering significant value to our shareholders, unquote. Gordon Gekko couldn't have said it better. So it'll be interesting to see how academic institutions respond to the growth and their movement into that sector. But thinking about all these groups of corporations, policy changes aimed at fixing corporate behavior won't have much impact without broader changes and pressure from without. There are many wonderful idealistic docs, but practicing clinicians and their professional societies have economic interests that are quite obvious. The payment system reimburses procedures far better than evaluation and management. Inevitably, procedural specialties resist redistribution of income to cognitive fields by occupying 70% of seats on the RVU update committee, which advises Medicare on fees. And they often produce guidelines to justify their activity. They minimize risk by optimizing insurance, and they run the till as long as they can. In my early days at UCLA, residents used to joke that the cardiologists only had two indications for heart cath, lub and dub, the two heart sounds. So everyone with a heartbeat met the requirements. The way in which the health system pays for services shapes the way in which physicians practice. And as you're all aware, the income differences between the procedural and cognitive fields are stark, and in fact have grown since the resource-based RVS was implemented in Medicare. And it's not like those, at the lower end, like general internal medicine and family medicine and pediatrics, ID and endocrinology are the wretched of the earth, far from it. But the disparities are very, very apparent, and they have an effect. And at the same time, though, doctors weren't selected into medical school to be empathic, caring, and altruistic. Many handle uncertainty poorly, aren't well trained to limit care, are more comfortable with narrow tasks like procedures than building relationships with patients. Accordingly, the choices that many make of specialties are driven by efficiency of income generation, and communicating effectively with patients is not well rewarded and often is actively avoided. David was a medical student doing his third-year clerkship in internal medicine. Very smart, highly motivated. I was the attending physician. His knowledge of disease and treatment was at a very high level. He interacted extremely well with the team, with the nursing staff. He was terrific with patients, sensitive, open, caring, and committed. He loved what he was doing. It was clear. I shared my impression with David. I told him I believed he'd be an outstanding resident in internal medicine. He told me he loved the rotation and could imagine himself in internal medicine, but that he'd been advised by other students not to do that. Quote, "Your test scores and grades are too good, it would be a waste," unquote. They were saying that his level of medical school performance would qualify him for a higher paying specialty, but he promised to think about what I'd said. As you can see here, the proportion of residency slots filled by US medical graduates bears a linear relationship to specialty incomes. Several months after our conversation, David came by my office and asked for a letter of rec for residency. And I was happy to provide one, but disappointed to learn that he'd chosen to go into anesthesiology. And it's likely he'll be a terrific anesthesiologist, but his awareness of what it meant financially was, in a sense, a corrupting influence on his career decision. So why doesn't society value so-called cognitive fields like yours and mine more than it does? Such work is no less complex and demanding and no less life-altering for patients. I think part of the explanation is that we don't do a good job of getting that message out. And I can relate illustrative stories in this regard from my experience. A patient who needed constant coaching and repeated discussions of evidence and emotional support to stick with his treatment for his Hodgkin disease. A person who was dying and in pain, but needed to hear from a physician whom he trusted that it would be okay to end active treatment. A patient with severe hypertension and a serious mental illness that made it hard to adhere to treatment and show up for appointments, who needed a doc who would stick with her and keep her alive. A patient who was dispirited by multiple morbidities and needed her doctor to manage her complex regimen, but also keep her spirits up. These are complicated tasks, and we all have many patients and stories like this that we can and should share about the value of what we do. Well, can we change clinicians' priorities and competencies? Here are some ideas. Pay doctors for their time, not for piecework. Specialty pay should differ only modestly and only to account for differences in times and training. Incentivize clinicians to seek therapy to help them better understand and relate to patients, their needs and values. All physicians should have periodic training in communication and negotiation with patients, and along with their hospital administrators in ethics, morals, and social responsibilities, and mandate that procedural specialists and hospital administrators meet regularly to discuss strategies and set targets to reduce use of low-value care rather than the opposite. How about educational institutions? Universities and medical schools have considerable interest in the status quo and are part of the problem. Medical school admissions are limited almost entirely to those with great GPAs and test scores, and pay little attention to values and ability to empathize and communicate effectively. And not surprisingly, the great majority of those admitted have studied the biological and physical sciences and related disciplines, and overwhelmingly overrepresent those from privileged backgrounds and underrepresent Blacks and Hispanics. Medical schools do a poor job of identifying students with commitments to societal betterment that are more than window dressing on applications. The undergraduate curriculum is science-based and biologically reductionist. Humanities and social sciences are at best an afterthought. The white coat ceremonies on entry are an exercise in triumphalism for people who have accomplished nothing yet, but have been told that they've arrived. Students go through a well-described negative socialization and loss of idealism that medical schools don't show enough interest in arresting. And once selected, students don't learn nearly enough about how to relate to patients and next to nothing about ethical obligations and social responsibilities. Some who arrive purportedly intending to follow in the footsteps of Mother Teresa rapidly decide to pursue the highest paying specialties. Student debt can be considerable, but doesn't preclude eventually living in comfort. And it does provide a rationalization for those kinds of decisions. In terms of graduate medical education, in postgraduate and clinical training, there are many wonderful teachers again, but it's the exception, not the rule, when faculty model the kind of judicious, evidence-based application of technology and commitment to diverse populations that might make America less exceptional. Again, there's little exposure to humanities and social sciences, few opportunities to address doctors' personal challenges that stand in the way of effective relationships with patients, and little effort to assure they're able to communicate effectively with patients. Some institutions try hard to provide positive outpatient experiences, but in many programs, they're awful. Residents who are pressed for time are assigned patients whom the faculty don't want to see themselves. These features of the training, as well as the greater attention given to developing procedural skills rather than effective communication, promote choices of procedural careers. There are lots of potential strategies for fixing medical education, changing attitudes, values, priorities, career choices of medical school graduates. Here are some of my thoughts. Replace pre-medical science requirements completely with humanities, ethics, and social sciences. Lewis Thomas proposed this more than 40 years ago. Hasn't happened yet. Develop mechanisms to identify and select applicants driven by altruism, not prestige and income, and who demonstrate capacity and empathy, psychological openness, sound moral and ethical foundations, and sustained commitment to societal well-being. Members of underserved communities should nominate medical school matriculants. Ethics, morality, social responsibility, and communication skills should comprise up to half of the first 2 years of the medical school curriculum and be integrated into clinical training. Clinical training should consistently encourage psychological openness. It should give more weight to social context of illness and less to biological reductionism. Clinically, medical schools are no less interested than the private sector in generating revenue by favoring good insurance, maximizing market share, and so on. The health of the public is not a priority beyond the occasional lecture on the social aspects of medicine. Practices often are segregated by insurance type. As with their teaching hospitals, their business plans reflect the priority of revenue generation, grow market share, minimize risk, run the till. That's the so-called hidden curriculum. And students learn these lessons really well and grow up to emulate the practice patterns and values of their faculty. When I entered medical school, my uncle commented that I would have a choice between figuring out how to make a lot of money and how to best serve humanity, and that on the basis of my choice, people like him could judge my worth as a human being. That was a very provocative statement, but the provocation was a gift because I still ask myself if I'm doing enough. Many medical students and residents, and indeed their faculty, would benefit from such provocation. Research in medical schools is mostly funded by the federal government and industry. Schools have been increasingly interested in seeking revenue from patents and royalties, and the priority of maxing that funding, as well as the size of grants and contracts, affects their hiring decisions. Social scientists and humanists don't get patents, and they don't bring in large grants. So relatively few are hired, which limits intellectual diversity in medical schools. Promotion is mostly driven by funding and publication counts, and rarely is much consideration given to the importance or challenges of social and community-based research in hiring or in promotion. In thinking about science, it's worthwhile to consider Robert Merton's characterization of its ethos. 4 components: universalism, it's subject to verification, anyone can contribute. Communalism, the findings of science are products of collaboration and are assigned to the community, and this ethos is incompatible with technology defined as private property. Disinterestedness, which is objectivity about the outcome, and organized skepticism, which is suspension of judgment and detached scrutiny of beliefs. Does this ethos characterize medical research today? Not entirely. Basic scientists are mostly excited about discovery and not really educated about societal context or social responsibilities. Since the Bayh-Dole Act passed in 1980, patents can be lucrative for scientists and their employers, along with large grants and contracts. For some, they're a consummation devoutly to be wished. These priorities are apparent to their students as to what is important in science. Clinical research funding can be generous when it comes from industry. However, such funding, in those cases, the priorities are often those of industry, and intellectual freedom may be quite limited. In terms of later translational policy research, most of the researchers tend to genuflect before the status quo in terms of healthcare organization. And most do not look at substantial transformation, rather look at small changes in limited populations. Most of you are too young to recall Jess Unruh, but he was the California Secretary of State who ran against Ronald Reagan for governor. His famous axiom was, money is the mother's milk of politics. Well, it's also the mother's milk of academic research, and the NIH is the source. So where does the NIH dispense their milk? Well, actually, before we look at that, let's look at their mission statement. To seek fundamental knowledge about the nature and behavior of living systems and the application of that knowledge to enhance health, lengthen life, and reduce illness and disability. And its programs are designed to improve the health of the nation by conducting and supporting research in causes, diagnosis, prevention, and cure of human diseases. The NIH does not treat all aspects of this mission statement equally. Scientific organizations and funders like NIH keep promising miracles as a justification for increasing their budgets. And their relentless pursuit of molecular explanations affects the practice of medicine, encouraging attitudes towards disease as being largely asocial. It influences public perceptions, They produce a narrow vision of science, promulgating flavors of the decade to keep money flowing their way, and certainly not to other kinds of research that might have a larger impact on the health of populations. And of course, they fiercely defend their share of the research budget. When I wrote my first NIH project grant, an HIV outcome study, I got an excellent score, but it wasn't funded. When I spoke to the project officer at NIAID where I'd submitted it, he told me he was enthusiastic about it, but not to resubmit there because the director did not consider such research to be his responsibility. He redirected me to what is now the Agency for Healthcare Research and Quality. So you can see here the breakdown of the NIH's nearly $50 billion budget, along with that of AHRQ and PCORI. Some of the large institutes do support some behavioral and health services research, but many fluctuate wildly from year to year and are not a consistent source of support, or decrease support when directorship of the institute changes. Others essentially never support such research, and a few consistently do, but most of those that do have budgets that amount to less than 1% of the overall budget of the NIH. In terms of making medical science more responsive to societal needs, among the things we could do are training and social responsibility in science should be core and a substantial feature in scientific education. Revenue from inventions funded by federal grants should accrue largely to the government, not to the scientists and their institutions or corporations. Research on bringing effective care to populations should be the NIH's highest priority, and half the members of advisory councils of the NIH institutes should be nominated by members of diverse communities in their areas of interest. The government can be part of the solution, but is often part of the problem. The US federal government avoids policies that necessitate raising taxes. They're susceptible to corporate and interest group pressures. They're reluctant to limit care and offend constituencies. They ineffectively regulate the FDA, Medicare fees, and insurance products. They overpay for procedures compared to cognitive services, and their policies promote over-specialization. And they tend to dream about moonshots, which are typically asocial biological approaches, rather than society-wide programs that might do more good. Are patients and their families innocent victims in all this? I think not, although many do suffer the consequences of the behavior of other actors. But just as the scientist, the clinician, the pharmaceutical company, and the health system see healthcare as a commodity, so too do many patients. They want their share of the goods. Now, most would prefer not to pay for it. When healthcare consumes close to 18% of GDP, who wants to work 7.5 hours to pay for their healthcare? But they want the blood test, the scan, the bed, and the ICU. And beyond that, many treat life itself as a kind of commodity, wanting more days, weeks, and months of life, whatever the cost or consequences to others. There isn't more thought of the common good among much of the public than among those working in the health sector. Why is that? In part, it reflects a world in which almost everything is commodified, in which autonomy is unmediated by concern about dire consequences for the health of the public, in which some people feel entitled to get whatever they want, and in which many people are often not well connected to others, are replete with loneliness, insecurity, dissatisfaction with life, and are beaten down by the world. And they come to the healthcare setting looking for solace, comfort, companionship, a heart that's open to them in the way that the larger world is not. And unlike those demanding care out of entitlement, who often get what they want, these individuals encounter professionals not equipped to give them what they need. Their beliefs and attitudes may well be shaped by the government promising moonshots, a profession that can't or won't set limits, a scientific establishment that holds out the imminent promise of disease conquest, lack of clarity from government about what are the reasonable limits, and dogma from some religious leaders about when life begins and how it should end. Robert Bellah is a Berkeley professor, and his colleague's wonderful book, Habits of the Heart, provides useful insights. They wrote, American individualism has become an autonomy dissociated from meaningful societal integration. damaged by destruction of subtle ties that bind people together, leaving them frightened and alone. Many abandon any notion of finding meaning in relation to society as a whole, and in particular in the idea of the common good. When education becomes an instrument for individual careerism, it can't provide personal meaning or civic culture. There's a fractured imbalance between individualism and communitarianism. Underlying the actions of all the actors are the values and consciousness, of course, of society as a whole outside of the health sector: acquisition, exploitation, inequity, lack of communal concerns, mistrust, atomization, lack of fulfillment. Greed is good, poverty is weakness. Decline of religion is a source of support. Failure of public discourse to address these issues. And in healthcare, this manifests both in relation to the economic and political behavior of the actors and in terms of their inner lives. Yes, healthcare is commodified, and health and life as well. Everyone wants a piece of the pie. Some actors inducing demand and raising prices, others seeking greater market share of those with good insurance and marketing product lines, some running the till and never saying no, some interested in inventions that may enrich them. Patients are complicit, wanting their shares of care, health, and life. All these groups push for the system to do more. On the other hand, insurers, the government, employers, each in their own way and for their own reasons, often want to limit care and its costs and coverage in ways not necessarily consistent with optimal health. Only public sector providers and other clinics for the poor try to do the right thing, albeit with inadequate resources. When care is commodified, there's a disincentive to spend time talking to patients, relating to them, getting to know them, caring for them, an incentive to do more, selling them stuff. Surgeries for at best marginal indications, excessive consultation, higher copays, costlier insurance, exacerbating disparities, needless consumption of resources like ICU days, limiting access for others, and little time and few resources to address social determinants of disease and the context in which patients experience disease and treatment, and diversion of resources from other societal needs, such as social services, education, and infrastructure, which arguably could do more for health. But the idea of commodification of the marketplace, is it efficient? Is it better? Does it even work? Edmund Pellegrino argues, he's an ethicist, and was, putting clinicians at financial risk can lead to loss of professionalism. Market relationships rarely extend beyond the act of selling commodities, which has grave consequences in medicine, and only the government will place public good above private interest. Economist Kenneth Arrow says that healthcare can't meet the conditions of a perfectly functioning market because of uncertainty about the quality of the products that patients purchase. Injury to some caused by unconstrained markets may not be offset by benefit to others. So Pellegrino and Daniel Callahan concluded commodified healthcare is inherently unjust. And we know that among advanced economies, the relatively freewheeling market in the US healthcare system is perhaps the least efficient while producing poorer outcomes than so many others. But commodification isn't the only problem, and addressing it is necessary, but it won't be sufficient. Consciousness is no less potent a force. Clinicians who enjoy doing things that are concrete and short-term and have trouble saying no aren't going to limit care and change the system's priorities. Medical schools can't help but want to be generative of more and more specialists, nor do they know how to break with their propensity for selecting students based on narrowly defined visions of merit rather than on the basis of capacity to care. Corporate leaders lack the training or interest or incentives to pursue societal obligations. And patients who are run down by life in our society, who are isolated, who need human contact, who have pain that's literal and figurative and don't trust medical authorities from whom they're socioculturally distant, and who are confused by misinformation about what medical science has to offer, look to medicine for the healing touch. Scientists love to figure things out and are mostly oblivious to societal problems. And politicians want their moonshots and dramatic policies, but certainly don't want to offend any constituency that might drive them from office. The ensuing discourse is disappointing. Doctors selling procedures, providers advertising miracles, professional societies guarding interests, educators promulgating values of the status quo, scientists and the NIH making extravagant promises, corporate speech inducing demand and blocking progress, politicians talking about moonshots, and media sensationalizing reports of scientific advances and not putting them in proper perspective. Health policy researchers rarely threaten the status quo, and any public intellectuals trying to balance the discourse are drowned out. Jürgen Habermas's theory of communicative action is relevant. Progress in society depends on common understanding of ends and the nature of interaction across those who control capital and produce commodities, those who develop and implement policies, individuals and groups seeking influence, and the values and beliefs of members of society. And in general, capitalists communicate very well with policymakers. Others are shut out. In healthcare, the power does rest with capital, abetted by government and professional organizations. Absent common understanding, adversarial situations, such as malpractice suits, insurance denials, and collection agencies, misdirected priorities in research, clinical programs, and education, and poor communication and clinical encounters all ensue. We are left with a set of relationships in which all the players tend to reinforce the worst instincts in all the other groups. All of them exacerbate problems, and all of them lose sight of the common good. So what is to be done? Policy change can't be sustained when almost every group of actors wants it to fail. A number of philosophers, George Lukács, Karl Korsch, Antonio Gramsci, Herbert Marcuse, and Habermas, have all written about the prospect for substantial change and argue that just pulling a policy lever without addressing consciousness will lead to failure in the end. And in healthcare, there are so many material goods at stake and so many non-material factors that mesh with these arrangements that all the groups of actors are more inclined to bear those ills we have than fly to others that we know not of. So is meaningful change possible? So many actors are caught up in commodification of care. We talked about almost all of these, or many of these issues today, not all. Limited by their values, attitudes, and perceived needs, promulgating or receiving problematic communication. There's a lot on this slide, and there are other problems as well. But we need to take on a large number of challenges in this maelstrom of dimensions of commodification, consciousness, and communication in healthcare. Well, what can any of us do? What can academics do? Well, educators, clinicians, and researchers should think strategically about how many of these problems we can take on in our own institutions. All clinicians need to think about what we can do in terms of our own behavior. But even that's not enough, because when there are so many barriers to progress, we can't ignore them. This has been Vincenzo Camuccini's painting of the death of Julius Caesar, and it represents artistically our current conundrum in healthcare. It wouldn't have been enough to neutralize Cassius or Brutus, analogous to the fervent opposition of all the actors in healthcare to the prospect of reform. Everyone who greeted Caesar in Pompey's theater on the Ides of March wanted him to be dead. Changing policy won't be enough. Transformation has to occur at all the levels that we've discussed, and combination therapy is going to be needed. Until that happens, innovations like the ACA, which does represent a modicum of progress, are like treating lymphoma or HIV with one drug. They make a difference for some, but will be undone by the underlying malady. So you may ask, well, can we achieve justice in just one sector of society? Are docs and others going to embrace egalitarian, communitarian, ethical, non-commodified healthcare when the rest of society is going in a different direction? Well, we shouldn't shy away from thinking boldly and broadly about what it will take to achieve justice for all in healthcare and society. In addition to changes in clinical practice, education, and science that we've talked about, There are other changes that are needed, and I'll flash through a few of them. But it's imperative that we act in our professional capacities, but also as citizens to promote these changes. Silence of health professionals is assent, as was noted in a JAMA commentary a few weeks ago. Government needs to move in and provide the same insurance coverage to everyone, a single payer. Separate insurance is never equal, as with other things in society. Approval of treatment should be contingent on assuring that they're available to everyone and cost effective. The national academies should convene a panel to propose a substantially revised set of budget priorities for the NIH that gives much more emphasis to population health. And if we can't get rid of the fee-for-service system, at least radically revise the Medicare fee schedule. In terms of communication, health systems shouldn't be advertising their product lines. At most, they should be promoting public health. Stop overselling the implications of biomedical science. Stop selling patients procedures that they don't need. More transparency about medical prices and balanced reporting on the implications of new research. In terms of what the public needs, provide them the social services and financial resources and psychological resources they needed that are best dealt with in those ways. Educate the public and patients about the common good, fair distribution of limited medical resources, and the limits of what medicine can accomplish. Train clinicians who truly can relate to and communicate with diverse populations, and incorporate communities into all levels of decision-making in education and clinical care and research. To change the trajectory of healthcare, we have to take on a lot of this stuff. We do have to change consciousness. We also have to transform discourse about healthcare and relationships within it. We need to pursue a consensus that we're all in the same boat. And we shouldn't give up with each failed effort at reform. There'll be many. And it's 2 millennia ago, Rabbi Tarfon wrote that it's not your duty to finish the work, but neither are you at liberty to neglect it. And so I'll end with that and look forward to some critique and comments and questions. Thank you.
Thank you, Dr. Shapiro, for a very, very provocative talk. You, interestingly, you ended with my absolute favorite quote, because I really feel like that is the challenge of all of us as we think about sustainability in our career is what can I do to contribute to the work, even at the same time realizing that I will not finish this challenge alone. So I guess that really leads me to kind of a key question. I'm so, you presented a lot of material and I really appreciate the insight that you shared and the breadth of what you feel like needs to change, the breadth of your vision. As a primary care physician seeing patients, or even as an academic physician who's working with trainees, where's one place that I could start in making that difference?
Well, I mean, I think we can't just do one thing, and I'm clearly trying to make that point. The time and again efforts to reform the healthcare system run into barriers. Efforts to revise the fee schedule run into landmines throughout the field anytime someone tries to tiptoe in there. I think we have to take on all the things that we can. But I think in medical schools, a good place to start would be to radically revise who we select. There's actually no reason. If you're going to be a scientist, you need to know a lot of science. If you're going to practice medicine, you have to know enough science to make decisions that are logical or sensible. And the science will often change anyways. And a lot of that, and it can all or almost all be learned in medical school. So, but really figure out how to identify people who are going to be the doctors who care about people, who are going to be the doctors who aren't driven by the desire to make more money, but rather by the sorts of values that will help us build a healthcare system. As technology advances, it becomes even more critical that we use it judiciously and appropriately, and provide people with the care that they need and deserve. And the medical school curriculum needs to change accordingly. People are wondering if you need a third year of medical school. Well, how about, I mean, as I said, make serious efforts to not just instruct people on communication and maybe have them observed a couple of times here or there, but to really, really work with them and help them become the kinds of doctors we would like them to be, and to try to defend them, immunize them, you develop an RNA vaccine against loss of idealism, among those who still have some. So that would be one place to start. I think the revising insurance is clearly another. I think in terms of the science community, it's absurd that that billions and billions of dollars are invested by the government in products, and then companies step in and make enormous profits and then jack up the prices as much as they can. Then there's lots and lots of things that we can do.
I appreciate that answer. I really do. And I want to share a couple comments from the chat or the Q&A in case you haven't had a chance to see them yet, because I know you've been busy talking. Dr. Anjana Sharma wrote, "This is a comprehensive diagnosis. I was curious about the choice to not consider capitalism as the root cause of our current condition, which appears to be centrally counter to the idea of health as a common good and human right." So Dr. Sharma asked about that. And then in just the interest of time, I'm also going to share Dr. Mike Potter's comment, which really agreed with the broad indictments of our healthcare system, but was asking, where do you see the glimmers of hope? I realize that's a lot to answer in the last 3 minutes, but I want to give you the final word here.
Yeah, I mean, I think capitalism is a problem, and I think we need to transform society. But it's a nuanced set of things that needs to happen. I mean, the philosophers who I cited all were fervent, critics of capitalist society. So that certainly needs to be fixed. But we can't cop out in medicine. It certainly doesn't appear that any of the leading candidates for president in the U.S. Is going to displace the capitalist system. So we can certainly keep in mind what a long-term goal is, but at the same time recognize that there are lots and lots of things that need to happen, and lots of changes that might occur in society that I think will fall short if there isn't broader change in society. But you have to do what you can do. You have to undertake what you can undertake. And certainly articulating the problems and beginning to try, even if we fail to address them, ultimately may move the needle in the long run in the direction of a more just, not just healthcare system, but society as a whole. So, it's interesting, at the end of my book, and I know you're reading it, I have a quote from Max Horkheimer, and you could say, oh, this is, this seems overwhelming, it's impossible. But he said, the method of negation, the denunciation of everything that mutilates mankind and impedes its free development, rests on confidence in man. So I wrote this because I'm an optimist, because I think we can solve this. Just doesn't appear like it's going to happen in my lifetime. So use guys out there, including the other Martin Shapiro, the one who is not my replica, or I don't know what they call those things. You got to go out and solve this stuff.
Thank you, Dr. Shapiro. I think that's an incredible ending for us and a rallying call for the younger generations, but all of us in the older generations too, to go out and make our mark. I really appreciate your sharing your thoughts with us today, and I look forward to all the conversation that this Grand Rounds is going to bring. So thank you very much, and thanks to everyone for joining us.
And if you do read my book, I'd be very interested in your thoughts and critiques, because there's much more that needs to be said about all these problems. Thank you all, and have an excellent weekend. Bye now.
Thank you. Bye-bye.